Thank you for joining me here today. I'm so happy to have you here. This is Carmen Coffin with Taking Care of Us. I am going live today from my personal page, and then I'll share it over to the group. I wanted to talk a little bit more about what we started talking about on Tuesday, which was the fact that a friend of mine asked me to give my opinion on some remarks that Dr. Anthony Fauci had made April 7th at a press conference regarding the COVID-19 coronavirus. This article was in Business Insider, and I had to do a lot of research to give my opinion because I didn't just want to come off the top of my head. But here is basically what was said that day. This Dr. Fauci's comments. I see a similarity here because health disparities always existed for the African American community. But here again, with the crisis, how it's shining a bright light on how unacceptable that is, and that being the health disparities in the African American community. And the article went on to say that Dr. Fauci, along with Dr. Deborah Birx, noted that there were no biological reasons that African Americans were dying or are dying at higher rates from COVID-19. Dr. Fauci said it was not the case that African Americans were getting infected more often, but rather that the prevalence of underlying medical conditions, diabetes, hypertension, which is high blood pressure, obesity, and asthma, had led to higher intensive care admissions and death rates. And the last thing that the article said was that Dr. Fauci told a reporter later on that the trend was not limited to particular cities or states. The underlying reason why this is happening does not change from state to state. And the disproportionate impact of broader action once the dust settles. He said, so when this is all over, and we said it will end, we will get over coronavirus, but there will still be health disparities, which we really do need to address in the African American community. So I want to stop here and just say, let's make that a call, a clarion cry. Let's make sure that that's something that we as people push for as after this virus is, the pandemic is over, and that would be a way to advocate for change. There are reasons why there are underlying health disparities in the African American community. Some of those reasons, there are a lot of reasons. And so we've been addressing some of those. So we started on Tuesday and we talked about the Flexner report. So I want to go a little bit deeper into that. I want to go a little deeper into why we don't have as many African American doctors who serve the underserved population. First of all, there were doctors in America before and during slavery. So I want to put that out there. Doctors were not always trained in a medical facility. So, but I will say the first medical school that was established in the U.S. was the University of Pennsylvania School of Medicine, which opened in 1765. We know that. I can't say that there weren't any other medical training facilities started before that, but that's the first medical school that that we know of. But besides this, there were healers who came to the States, whatever fashion, from Europe and from Africa, as well as the American Indian healers who were already here when America was started. And the healers were generally trained by passing down an apprenticeship from the healer to the trainees. So there may have been a healer who had a garden with herbs and things that, or They knew what to go and get from the wood to use in certain ways to create a healing process for someone who was sick. This wasn't formal medicine. Formal is what we know it today, is because you go to college, you go to medical school, you do a residency, you choose a specialty. That's the formal medical training that we know today. But it was considered training, to be trained in how to heal people. Many people could not afford to go to doctors then, just like today. A lot of people cannot afford to go to the doctor. And so they used the healer services exclusively. There were, you would send a child, or you would send a relative to go and get the healer, and they would come and examine you and determine what the need was, and then they would fix that. So healers use poultices, which are compounded things that I don't know what they used. There are lots of different things that went into poultices. There could be certain kinds of mud. There could be certain kinds of herbs. There could be certain tree barks. There could be leaves. Poultices were solutions that were created and compounded, and generally maybe put into a certain kind of cloth and laid on certain parts of the body to help heal. Sometimes they were foul smelling, sometimes they were ingested, which means they were taken by mouth. It just depends on what the healer was trained in and knew that would be the best thing for the symptoms that they saw. Each healer worked with the knowledge that they had been trained in. So if you had been trained in England or Scotland or Ireland or some other part of Europe, or if you'd been trained in different parts of Western Africa or Central Africa, wherever you came from, you learned where you were before you came here, the things to use, and you could identify things when you got here that would either replace it or could be used. Some people brought their own things with them when they traveled. I guess if they knew they were coming across the water, they would bring their own medicines and herbs with them. I'll be doing more research on that, and sharing some of that later. So the article that I mentioned on Tuesday that caused this upheaval in the medical schools that we had was called the Flexner Report. It was written by Abraham Flexner in 1910. He was commissioned, but he asked for the employment. In my research, I found he asked for the employment a couple of times. And he was an educator. He was not medically trained. He did not have any training in the medical field whatsoever. But he did, I guess, think that he could go around the country and figure out what needed to be done in terms of creating quality medical schools. During the time that the Flexner Report was written, the Black population in the United States was about 3% of the total population. And most Black people were not able to see white doctors. For whatever reasons, they would not see them. They could not afford to see them. I remember there were only certain white doctors when I was growing up in the rural areas that would see Black patients, and they couldn't come to their office, so they would do home visits, because my assumption is that white patients didn't want Black patients in the same facilities as them. Part of that is why there were separate hospitals as well. So back to the research. So when proprietary, which, as we said on Tuesday, were medical schools that were created for-profit schools, and they were created by people who were just teaching what they knew. There was not necessarily the formal medical information behind them. There was no like, you didn't go to school for 4 years and then go to school for 3 years. You might have started school in the fall and graduated in the spring. You might have had a high school education and you might not. All of those things, there was no determination that this was what had to be for each school. So there were no rules and regulations for all the schools. So when the proprietary and smaller medical schools were closed as a result of the AMA, the American Medical Association's acceptance of the Flexner Report, fewer African Americans were able to see trained physicians. And so consequently, there was more sickness and disease. If there's no way to treat someone, then they just get sick. Or there's no way to cure something, then people just got sick. So here's some of what Abraham Flexner wrote in his report. And it frustrated me to read it, but just ask yourself when I get to the end of it, how do you feel having heard the words that he wrote? Okay, this is all quoted. The Negro needs good schools rather than many schools. So there were 14 medical schools. I'm coming out of the quote now. There were 14 medical schools for African Americans at one time. At the time that the Flexner Report was written, there were only 7. So of the medical schools for Negroes in the United States, 5 are at this moment in no position to make any contribution of value. Flint at New Orleans, Leonard at Raleigh, the Knoxville, Memphis, and Louisville schools are ineffectual. So, another comment here. Those 5 schools failed, and consider that the financing of most of the financing of these schools was by white Northerners or medical or aid societies. Those schools were already struggling financially, and much of that support was withdrawn after this report was finished. Abraham Flexner further stated that Meharry at Nashville and Howard at Washington are worth developing. The Negro must be educated not only for his sake, but for ours. 10 million of them live in close contact with 60 million whites. How does that make you feel to hear that? That was written, that was accepted, that was used to close down schools, because that was an end goal. That was an end goal. Anyhow, think about how that makes you feel. Comment. Let me know what you think about those words that I just spoke. So from 1910 until 1966, after 5 of the remaining 7 medical schools closed down, so there were only 2 Black medical schools that were training Black doctors. Just remember, I said yesterday, even here in North Carolina, there were separate hospitals for Blacks and whites until white med did not open to Black people until 1960. So anyhow, from 1910 till 1966, that's 55 years, there was not another Black medical school founded until the Charles Drew Medical School was established in Los Angeles. And of course, if you couldn't go to a Black medical school, and they could only take so many students, the number of Black physicians obviously decreased, but the number of white physicians increased. Okay? So just from the statements that I've said earlier and the fact that Abraham Flexner was not a medically trained person, not to mention the fact that the American Medical Association and the Association of American Medical Colleges had already begun to improve medical education. There's already evidence that smaller medical schools and those that were proprietary in nature were going to be pushed out of the way for a different type of medical training. This is not to say that it was not important to have medical schools that had quality education, but it's to say that the quality in this instance harmed the Black population from having doctors that were trained and able to practice in their own communities to help those that we now call underserved populations, because they didn't have the financial abilities to maintain the types of schools that were considered quality, and they couldn't compete with the larger schools. And several of the larger schools got larger because there were deficiencies mentioned in this report. And so some of the larger schools would merge together to make sure that they had all the things that were listed as necessary for quality medical schools. To this end, the underserved population and people of color make up the disproportionate or the larger part of that population, have not had the adequate type of care. So that's the end of my research. That's not the end of the things that I found out, but that is a step towards determining or recognizing that the underserved population was done a disservice in some manner because there weren't enough doctors to take care of that population. And that was a deliberate act to stop. I'll talk a little bit more about all of this on Tuesday. And I appreciate your coming on today and listening. Please feel free to share this and share part one. I don't know how many parts there'll be, but I kind of want to dig till we get to the bottom of this so that we know what we need to work on doing as a community, a big community, because it's going to take a big community of this disparity of healthcare in underserved populations. And I thank you so much for coming on today. Part of my story that many of you know, many of you may have heard before, is that I grew up a young Black child in a predominantly white neighborhood, and I didn't feel like I fit in anywhere. I felt very much alone. So one of the things that I did as an alone child, I loved to read. I read, I studied, and I like to deep dive and figure out, so where can we do better? What kind of things need to be changed? And let's listen to everybody in the process. Let's just listen to the community and hear what they have to say, and don't disregard what people have to say because they don't have quality stuff behind them. Thank you so much. I look forward to seeing you next Tuesday at 12 noon, and we'll talk some more about medical disparities.